So good evening, everybody, and welcome to the kickoff of this fall's Community Medical School. I'm Renee Stapleton, a faculty member in the Department of Medicine and the Division of Pulmonary and Critical Care. Some of my research also centers on end-of-life care, so that's why I'm here as part of the panel tonight. And the way this will work is that each of us will talk for about 10 to 15 minutes on a particular topic. And then at the end of the hour, we'll open it up for questions and hopefully have a really interactive, fun, and educational 30 minutes of questions and answers. Before I get started, I'd like to introduce the other three members of the panel. Immediately to my left is Dr. Bob Macauley. He's a professor of pediatrics and is the director of ethics, the medical director of ethics here at Fletcher Healthcare. To his left is Dr. Ben Suratt. Ben, like me, is a member of the Division of Pulmonary and Critical Care Medicine. He's also the Associate Chief of Pulmonary and Critical Care. And to his left is Dr. Ursula McVeigh. Ursula is in the Department of Family Medicine, and she's the Director of Palliative Care here at the hospital. So, I kind of got chosen to start things off by talking a little bit about the epidemiology or the background of death in the United States, to try to provide some, I think, basic information on what's going on in America now, what it's going to look like in the future, and to sort of lay the groundwork for the next three speakers to get a little more in depth on their particular topics. Other than the fact that every single person in this room is going to die at some point, there are other reasons to think about this and to realize that it's really important. Now there are almost 2.5 million deaths every year in this country. As you all know, most of these occur in older Americans over the age of 65. And in another 15 years, this amount will double. Right, the baby boomer generation is aging, and that's what's happening with population in this country. From a cost standpoint, actually almost a third of the Medicare budget is spent in the last 12 to 18 months of people's lives. So it's not only important from a population standpoint, but also from a financial standpoint. So what do Americans die from? Dr. Macauley actually sent me this slide a few weeks ago. And here on the left side are the causes of death 100 years ago in 1900. I actually think one thing might be missing from that list, and I'm curious why it's not on there, but in 1900, childbirth was a reasonably common cause of death too. But you can see that things like pneumonia, tuberculosis, infections took up half of the deaths in 1900, with things that we think about now, like heart disease and cancer, being a lot less common. Now, though, 110 years later, heart disease is the most common with 20%. Cancer also occupies another 20%. And then the remainder of the deaths are filled up with those things that you see over there on the right. How do these deaths occur? And I think in general, the way we die kind of happens in three sort of flavors. The first, they can be really sudden, right? This is the person, all of you in the audience probably know someone to whom this has happened. They might be asleep and they have a heart attack at 3 o'clock in the morning and they have an arrhythmia, a funny heart rhythm, and they die immediately. Some of us even, on the other side, there are also people who have prolonged chronic illnesses like heart failure, emphysema, maybe a prolonged cancer, and they slowly get worse over months or even years, have a lot of time to prepare, although they might be suffering substantially. And usually, I think in this setting, something sort of acute at the end happens. Maybe they get a pneumonia, maybe they get sick for another reason. Something like that happens as kind of a final event. But they've been in preparation for a long time. I think maybe more commonly, though, is kind of this middle ground. where there's not really a terrible chronic illness that's slowly getting worse, but somebody might get ill. I just put an example up here. Somebody might get ill with, say, influenza, and then gets a pneumonia 2 or 3 weeks later, ends up in the hospital, and kind of one thing after another happens, and that person might face death in a few weeks. How do we want to die? I think this is actually pretty interesting. These are results that I combined from several different surveys, which vary a little bit. But in general, if Americans are asked how they want to die, about 3/4 say that they want to die a natural death if their heart or lungs should stop. And only 5% say, no, I want doctors to do everything they can to prolong life at all cost. Then there's another quarter, 25%, that say, I don't know, and they want time to think about it. But it's definitely the majority that want to die a natural death. Now, where do patients want to die? This is part of the survey. 75%, the same amount that say they want to die a natural death, say they want to die at home. Whereas about 1/4 of patients say they'd prefer not to die at home for whatever reason. But this actually isn't what happens at all. The graph on the right is really what happens. About half of patients in this country die in the hospital, another 1/4 die in a nursing home or some kind of acute care facility, and then there's another 1/4 that die either at home or other, and the other is a pretty small slice. So what ends up happening is almost exactly opposite of what patients say they want. And I think this discrepancy has part to do with communication, part to do with education, and part to do with preparation. Now this is a study that was recently published in JAMA, which is the Journal of the American Medical Association, a pretty prominent premier medical journal. And Joan Tino is the lead author, and she actually looked at Medicare data in 2000, 2005, and 2009. And the yellow line up here is the percentage of patients that are using hospice at the time of their death. I imagine that most people in the audience have heard of hospice. It's an organization that provides care at the end of life where comfort is the primary goal. So between 2000 and 2009, you can see that there was a nice rise in hospice use from about 20% up to about a little over 40%. Now, kind of on the flip side, those patients that received ICU care in the intensive care unit in the last month of life increased from about 25 up to about 30. And you might look at that and say, well, great, we're using hospice a lot more. But actually what's happening, 30% of this 43% were referrals that were made within 3 days of death. Kind of an afterthought, almost. At least that's the interpretation by the authors. And interestingly, 40% of that 30% were preceded by an ICU stay. Again, kind of an indication that we as a country are really not doing a great job thinking about what our goals are, what our values are, and preparing for this event that is going to happen inevitably. So, to lay the groundwork a little bit for the coming 3 talks, what are the options? You know, first and foremost, you need to think about your values and your goals and what's important to you. And I'm not going to say much more about that now because Dr. McVeigh will finish up with a section on navigating serious illness toward the end of life. Secondly, you should really try to get educated and understand what care at the end of life looks like. What are the options? You know, I think almost everybody in this room probably knows what being in a hospital is like. You've either been there yourself or you've maybe been to visit someone in the hospital. But thinking about cardiopulmonary resuscitation, what really is CPR? What is life support? Talking about things like mechanical ventilation, being on a breathing machine, getting tube feedings, getting dialysis if your kidney fails, those are all part of life support. And I'm going to talk a little bit more about that in the coming couple of slides. Other types of care include hospice, which I think will be mentioned later. And then after you've done all that, the other important thing to remember is that you can choose to receive or not to receive any of these therapies. But the default is that, especially with regard to CPR, unless you specifically opt out and do that preparation in advance, if something sudden happens to you, you will receive that treatment, because that's how we currently operate in this country. So cardiopulmonary resuscitation. How many people have seen CPR on television or in a movie? Almost everybody. How many people have seen what CPR really looks like? Actually, quite a few of you. So those of you that have seen both, do you think they differ? Yeah, I'm hearing a lot of nods. So when studies have looked at what happens after CPR on TV or in the movies, actually about 60 to 70% of people in the media survive. And often they get a little pound on the chest, they get some mouth-to-mouth resuscitation, they sit up and cough a little bit and walk away. Right, that's actually not what happens in reality. I didn't want to put a video of CPR up here because it's actually unpleasant for some people to watch, but it's really, it's a reasonably intense, some people might use the word brutal, procedure. And it's used, chest compressions are done to make the heart pump from the outside. A breathing tube is inserted to make sure that we can breathe for a patient. Here in the picture, this patient is getting air from a bag. And a lot of strong medicines are used. So it's really a medical procedure that includes all these things that is delivered when your heart or lungs should stop. Through about 40 years or 50 years of history in the US, this has become a procedure that's provided to everyone default unless you specifically indicate that you don't want it. And we'll talk throughout this talk about how you can do that. It actually turns out that less than 20% of people survive this procedure to leave the hospital. Those are people who get CPR when they're already in the hospital. If you receive it out of the hospital, it's more like 12 to 15%. And those who do survive, not always, but most often, the vast majority have a lower quality of life than before they receive the CPR, and they're unlikely to be sent home from the hospital. So most patients spend some amount of time in a nursing home or another care facility afterward. I'm just going to show you a couple pictures of what life support in an ICU looks at. I imagine some of you have already seen this. Now, these are all pictures that I just got off Google, honestly, with, I put a little black bar over the eyes just to be safe. Here's a breathing tube that's leading over to a mechanical ventilator behind the patient, or behind the blue box that you can't see. There's lots of IVs here and other tubing. Here's another picture. This patient is undergoing dialysis. These aren't the same dialysis machines that we use, but this is a dialysis machine over here on the left, this blue thing. So you can see that it's quite a bit different than what you'd see in the media. I'm going to stop there, introduce Dr. Macauley, who's going to talk about ethics at the end of life. And then remember, in another 45 minutes or so, we'll circle back around and open it up for questions. So, Bob, forward, backward, green light.
Got it. Thank you. Thanks very much, Renee, and thank you all for coming out. I know it takes courage to come out to a talk like this and a conversation like this, because we're talking about heavy-duty things. So I appreciate you all being thoughtful and proactive about that. So we're going to talk a little bit about ethics at the end of life and how we make decisions for patients in really difficult situations. So the standard teaching that we have is we listen to patients, we try to figure out what patients want, and we're going to go down this list of, ideally, you would have a patient make a competent decision where you put forth the risks, benefits, and alternatives of something, and the patient chooses, as Renee said, I want this or I don't want that. And in the absence of it, we'll go down the list about different things that we can do in terms of trying to figure out what a patient would want. But the emphasis is on patient wishes, on what patients choose, what their goals are, what their values are. And it's easy to think, well, that must be the right way because we've always done it that way, and it's really not true. Because if you were to go back in time to the beginning of Western medicine, like back to the time of Hippocrates, we really didn't, as physicians, ask very much about what patients wanted because we were doctors. We knew what was best. We would do what was right for patients, and they would nod and say thank you, hopefully. And if we didn't think something was a good idea, we wouldn't offer it. And if we thought something was a good idea, we'd just go ahead and do it. So if you think about medicine past, beneficence is a term that we use for doing good for somebody, which is a noble thing. Taken to its extreme, though, beneficence might be called paternalism, where physicians thought they knew what was best for people, and we just went ahead and did it. And just to give you an example, this is a quote from Hippocrates, and I'd like to ask you to think about how this translates, if at all, into the modern world. So Hippocrates advised his followers to conceal most things from the patient while you are attending to him. Turn his attention away from what is being done to him and reveal nothing of the patient's future or present condition. That's probably not going to fly in the 21st century, is it? And so you might think, well, that was 2,500 years ago. Things must have changed at some point along the way. Well, they did, but it's remarkably how recent things changed. So they did a study in 1961, published in the Journal of the AMA that Renee already mentioned, and they asked physicians. They said, if you have a patient that you discover has cancer and it's untreatable and you know they're going to die from that cancer, how many of you would actually tell the patient you have cancer? And remarkably, 10% said that, yes, I would tell the patient. And the rationale presumably was, well, if they're going to die of the cancer anyway, why tell them that? Because that would just make them sad, and then they would die sad. Wouldn't it be nicer just to live your life? And you may think that that's a little glib, but the AMA Code of Ethics said something very similar. The first AMA Code of Ethics came out in 1847, and it endorsed, in this wonderful Victorian phrase, it endorsed the beneficent deception of patients with gloomy prognostications. And you might say, oh, that was 1847, that was 150 plus years ago. The first AMA Code of Ethics that took that out came out in 1980. So this stuff about patient rights, patients getting to make decisions, especially patients getting to say no to stuff that we think could help them or keep them alive, is a relatively new development. So over time, the pendulum has swung from beneficence over to autonomy, or literally self-rule, where patients get to make their own decisions. So what are those rights that patients have in our modern world, at least over the last few decades? Well, a competent patient, so a patient who understands what's going on, what their condition is, and what the questions are being asked of them, has the right to refuse any treatment, even one that is necessary to keep them alive. And that is a relatively new idea. It came out in the courts and also in the legislatures in the 1970s. But that's very well established in American ethics and law now. So if you understand what's going on, you can say no to anything, even if whatever you're saying no to is necessary to keep you alive. The flip side doesn't necessarily hold, though. Just because you can say no to anything you don't want, it doesn't mean, as patients, you have the right to everything you do want. Because some of the stuff you do want may not be appropriate. It may not work. It may have too much risk associated with it, or we may not have enough of it to go around. So just because you can say no to everything, which is sort of an absolute right, it doesn't mean you can say yes and get whatever you want, because there's a whole system out there that has limitations in it. So patient rights, this incredibly important development, happened around the 1970s. So they said, well, let's see what happens with physicians and if they've changed. So in 1979, they did the same study they did in 1961, and they asked the same question to obviously a different group of doctors this time. Would you tell a patient if he had cancer, if you couldn't cure it? And now 95+% said yes. So this is a huge shift over just a couple of decades. So that's the ideal in my world. A patient understands. They get to make their own decisions, and we defend their right to make their own decisions. Well, a lot of times when patients are sick enough that they have tough questions to answer, they're not able to answer the questions Maybe they're so sick they can't think straight. Maybe they're sedated because they're on intensive medication or intensive treatment. So what do you do there? Well, here we do look for what we call substituted judgment. We find someone who knows the patient, and we say, well, what do you think they would say? Who are they? What are their goals? What are their values? My mentor in clinical ethics, who's here tonight, taught me to say to families, not a specific question, but to say something open-ended, like, tell me about the patient. Who are they? What makes life worth living for them? What's important to them? Now, that's what we try to do, but there are problems with that. One of which is people don't always know what somebody else wants. So if you think about the people in your life, the people you're closest to, that you've known maybe for years or decades or a really long time, maybe you live with them, maybe you have lived with them for a long time, how often do people like that do something that surprises you? Who you say, wow, I never knew you thought that, or I can't believe you do that. It happens, right? So they've done studies where they take patients who, just normal people who will be patients one day, and they're named decision makers, the people they want to make decisions for them, and they'll separate them into two rooms and they'll ask them both the same question. They'll say to the patient, what would you want in this situation? And they ask their friend or their loved one, what would the patient want in that situation? And they found that those two answers only agree about 2/3 of the time. So sometimes people surprise us, and we should have conversations about these difficult things with the people who we trust most. They've also found a significant emotional burden for people who are forced to do this, who are forced to make decisions for their loved ones. So I'm going to encourage you in a second to name a decision maker, because that's an important thing to do. If you can't make decisions, who should make decisions for you? And sometimes people say to me, well, what am I going to do? I have 3 adult children and I don't want to play favorites. And my response is, trust me, naming someone as your decision maker is not playing favorites. It's not a gift. It's a responsibility, and a sacred responsibility, because that's a really tough position to be in. And if we can help someone succeed at that by telling them what our goals and dreams and hopes are, that'll make it easier for them. And it's not just a question of what the decision is, but also who makes it. So this is a very busy slide, basically looking at the United States. And the red states are the states where if someone has not formally named a decision maker, it automatically reverts to their spouse, who gets to make decisions for them. There are a bunch of different other categories here, but you'll notice in white, no priority specified, and we are up there. And Vermont is white on this graph. And what that means is, according to Vermont law, if you have not named a decision maker in a durable power of attorney for health care, and you can't make your own decisions, in the eyes of the law, it is entirely unclear who should make decisions for you. Now, in the real world, we usually turn to the spouse if there is a spouse, and that's fine. But it's not absolutely clear in the eyes of the law, and sometimes there's not one person who's the obvious choice. There are multiple relatives or multiple loved ones, so it's always helpful to name somebody who would make your decisions for you. So if you ever get scared about filling out an advance directive because of all those questions about what do you want and what you don't want, there's one question in there that's really important, which is who makes decisions for you if you can't. And I ask this of physicians when I talk in groups. I say, if you have one question, imagine patient rolls into the ED, into the emergency department, and you have no knowledge of this patient at all, and you can ask one question and they can answer it, whatever it is, and then after they answer the one question, they become unconscious, so you can't ask them any more questions. I'm a philosopher, I get to make up these crazy scenarios. What would the one question be? And people guess things like, do you want me to help you? Or, which hopefully the answer is yes. Or do you want CPR? Or do you want to be full code? Or all this stuff. And eventually somebody says, who do you want to make decisions for you if you can't make them for yourself? It's kind of like, you find a bottle on the beach and you open it and a genie pops out and you get 3 wishes. What's always your 3rd wish? More wishes, right? So this is a way of saying, I'm going to ask one question and get more answers as a result of it. So please, if you're going to do advanced care planning, think about not only what you want, but also who you want to make decisions for you. All right, a few basic ethical principles. Withdrawing and withholding life-sustaining treatment. A lot of times people think that once you start something, you can't stop it. And that's not true. So there's no ethical difference between not starting something and stopping it once it's already been started if it's not doing what it's supposed to do. So you shouldn't be in a position of saying, well, I don't want to say yes to something because once I say yes to it, I lose all my rights, or I got to keep doing that forever. That's not true. You can try something, and if it works, that's great, and if it doesn't work, we can stop it. There's also no legal difference between those two things, but it is important to recognize that there is an emotional difference, especially for families. So if a family says, we don't think our loved one would want to go on life support, that's a really hard thing to say. But for a loved one who is on life support, to say, we don't think he or she would want to continue, so we think it's okay to stop that thing that's keeping them alive, well, that's even harder from an emotional point of view, and I think that's important to recognize. And a lot of times physicians don't understand this either. So this was a study that asked physicians and nurses, in this case, in pediatrics, but it would also carry over into the adult world too. Do you agree that there's no ethical difference between withholding a life-supporting measure and stopping it once it's been started? That is a true statement, as we just learned. And the majority of critical care physicians recognize that as a true statement, but every other specialty among physicians and nurses, only a minority did. So a lot of physicians and nurses don't get that. So you might need to help us along with that by being clear that you can start something and then stop it. A couple of comments about informed consent and end-of-life care before I wrap up. It's not uncommon in my business to encounter patients or families who say, well, I want everything done, or I'm full code, or I want to be full code. A couple of thoughts about that. Nobody really wants everything done. If you knew how much everything was in modern medicine, you would not want us to do all of that stuff to you. Nobody wants that. Nobody really wants CPR. Like, I don't think anybody wakes up one morning and says, wow, I really hope I get CPR today. Especially after the way Renee very accurately depicted it. It's not, a lot of things we do to people are burdensome. Nobody really wants that, but they want whatever is on the other side of that. They're willing to go through that, whatever that is, ICU care, CPR, chemotherapy, not because they want to go through it, but because they want to get to the other side to achieve their goals. And so it's important for patients to understand what the odds of getting through that are, what's going to be involved in getting through that, and can they really achieve their goals. And those goals are a lot of things to different people. Longer life, increased function, improved quality, less pain, whatever it is. It's important to identify what those goals are. But to make an informed decision, you need to understand what the goal is and what the chances of achieving it are and what you have to go through in order to get it. And my last slide, and just to reiterate what Renee said earlier, they did a study in the New England Journal of Medicine a few years ago where they looked at CPR on TV and they looked at it in real life, and exactly as she said, on TV, most of the people undergoing CPR are young. That's not true in real life. Most of the people on TV have healthy hearts and some other problem that if you fix the other problem, then their heart would turn out okay, and that's not true. And on TV, most people survive to discharge, and as Renee said, that's also not true. So in terms of the decisions, these are hard things, but it's important to be working with people who understand the facts to empower patients and their loved ones to make informed decisions so they can figure out if it makes sense in terms of their own respective goals. So I thank you for your attention. At this point, I'm going to turn over to Ben Suratt, who is a pulmonary critical care physician here at Fletcher Allen, who's going to take us through some work on prognostication. Do you want this? No, it's okay. Okay.
Well, thank you, Bob, and thank you all for coming out this evening. So as a practicing critical care physician, when I was thinking of a topic to discuss this evening, I thought I would actually pick what I think many people, at least initially, would consider a fairly narrow topic, which is prognostication and end-of-life caring and then decision-making. And I hope to explain why I think this is part and parcel, really, to most of what happens at the end of life. Of the three branches of medicine, we're most familiar with diagnosis, which really is the explicatory area of etiology and pathophysiology of disease. Treatment, which is the real managerial piece of medicine with plans for action to reverse the disease. And lastly, we have prognosis, which some authors have described as the wicked stepchild of medicine because of the lack of respect and attention it gets. The definition of prognosis is a prediction of the probable course and outcome of a disease. Now, one thing one would immediately ask in this context, as we're discussing end-of-life care, is, well, does prognosis really matter? And I think that we would even sometimes ask this question is really telling that I think we have very little experience with prognosis and prognostication itself, and often it's bad. Prognosis, by definition, is really the cornerstone of informed consent. I mean, if I'm going to consent somebody to a treatment or a procedure, any kind of diagnostic work, I would have to tell them that here's why we're doing this. If we do this, here are the risks, which is a form of prognostication, and here are our options, and if we don't do this, what happens? So even though it doesn't sound like a prognosis is being conveyed there, it is, absolutely, and it's really a cornerstone of understanding what we're talking about doing or having done. With the rise in chronic illness, prognosis has become much more important than it was, say, 150 years ago, when death tended to be earlier and often much more sudden. Prognosis takes on a life of its own in the era of chronic neuromuscular diseases, malignancies that are treatable but not necessarily curable, and certainly many of the other illnesses that we face, such as COPD and heart disease, which have become more chronic illnesses than acute causes of death. As I was arguing, prognosis is really fundamental to end-of-life decision-making. End-of-life itself is a prognosis right there. So for me to say that we're discussing end-of-life regarding a patient really means that I've put a prognosis on the table. Prognosis really drives advanced directives. Oftentimes when I am reviewing advanced directives, they'll say, in the case that there is no hope of me coming off a ventilator or of me surviving hospitalization or me returning to independent living, I do not want these things done. And that is really then incumbent upon me to make that kind of prognostication. Certainly, the other area that this has received a lot of attention in is in eligibility for hospice, particularly in Medicare. You have to be able to give a prognosis or a life expectancy of 30 days, or is it 6 months, sorry, 30 days. Spent too much time in the ICU. 6 months or less, and certainly now with the law that is coming online in Vermont, we also have an action that's predicated on a prognosis of 6 months or less in PAS. Now, certainly end-of-life prognostication is integral to treatment decisions, as I mentioned. In addition to advanced directives, whether or not we're going to do something to someone really comes down to what the benefit's going to be, what happens if we don't do it, and how long things will last, or if I intubate somebody, will they ever come off the ventilator? It's all wrapped together. So it really is important. And patients know this. This is something that we get asked all the time, prognosis. And this is actually from a commentary on 2 studies that were performed in the 90s, or the late 80s and 90s, of cancer patients. And what the author said was the highest priority for seriously ill patients, eclipsing their interest in treatment options or diagnostic details, is prognosis. So it's important for us to do our job. It's important for patients to make their decisions. And it's one of the most important things that we can discuss when people are very ill. Now, this is a quote from Nicholas Christakis, who is an MD and a sociologist at the University of Chicago. And I can relate to this observation as many of my colleagues can, and that is physicians regard prognosis with anxiety and disdain, and they avoid it if possible. And particularly, in the past several decades, this has been very true. And it still gives a lot of us discomfort when we're forced to give a prognosis. And I'm going to talk a little bit about why that is. And also, we'll talk a little bit about whether it's that physicians are unable to give a prognosis, as one might think if we just don't have the training or can't do it, then we would be unable. But I think there's something more going on that Bob alluded to that goes with being unwilling to convey a prognosis. Well, how good are we at prognosis? Well, not very good. This is a graph of predicted survival in days on the y-axis and observed survival in days on the x-axis. And this is from a study of nearly 470 hospice patients. And this is the predictions that the physicians made with them entering hospice against then how long they survive following their admission to hospice. And as a general observation, those dots above that unity line, that's the diagonal, are over optimistic prognostication, and those dots that are below the line are over pessimistic prognoses. And what we see is that there can be quite a bit of variability, and we can see patients who were given 30 days who live 3 years. We can see patients who were given 1,000 days, so over 3 years, less than 3 years, and yet died at 30 days. So now this, when you pick out a point at a time, bridges on really on anecdote. But if you look at it in its whole, it really does tell us something about prognosis and how good we are at it. And the fact that on average we tend to be, which surprised me, a bit optimistic. I tend to think that we often go on the other side. But if you define accuracy as being off by a third on either side of their actual time to death, physicians were only right about 20% of the time, which is pretty poor. Physician specialty heavily influenced the accuracy of the predictions. The medical subspecialties, such as myself, were particularly poor at this. Geriatric, general internal medicine were a little bit better. Oncology was actually significantly better than, say, I am, but they also, and this may not be a surprise to some people, are the least likely to be over-pessimistic. They tend to be very optimistic in general. The other specialties, the numbers were lower, but they range from about a quarter to a third of the time were they accurate. So why are we bad at this? Well, diagnosis itself alters accuracy of our predictions quite a bit. Cancer has been shown as a diagnosis to be often more accurately characterized in terms of prognosis and survival than, say, COPD. We're notoriously poor at making predictions about survival with COPD. Things that surprised me that had no influence on accuracy included the physician age, sex, self-rated optimism, or years in practice, which goes against a lot of what we tend to think about. Well, if I'm an optimistic person, maybe I give optimistic prognoses, or as I practice longer, I will be better at this. It's not always true. 57% of physicians in another study, however, felt that their training in prognosis was deficient. So that's more than half of physicians who are asked this question. And I think that is where this difficulty often lies. Prognosis is frankly understudied. Only 4% of published studies that were reviewed in one of Christakis' paper from 1946 and 1976 actually addressed prognosis itself. Prognosis is not a focus in our training quite often. As treatment options have increased, prognosis really has receded, and I'll show you a graph that demonstrates that in a second. So here, and this is a little bit hard to see, but here is a graph that Christakis published of the percentage of a chapter that in a medical text, this is the same medical text since the turn of the century, the percentage in pages of pneumonia discussion that applied to presentation, diagnosis, therapy, prognosis, and complications. And if you can't see where prognosis is, it's because it's down here on the axis. So we don't spend a lot of time discussing this. Now, you could say, well, pneumonia, I mean, people get better from pneumonia now. We have antibiotics. We do much better. But what I'd say is I read an article, a review in New England Journal last week of sepsis, which is a condition that I study and treat. And of a 10-page article, exactly one paragraph was devoted to prognosis and outcome. So I think we still do not do a great job. One of the things that was really interesting in this research was, and unpredicted, was that the longer the doctor-patient relationship, the greater the error in prognosis. Now, that's one of those things that makes you stop and think. You'd think the better I know you, the better I'd be able to predict what's going to happen. But this begins to get at something that I'll talk about next. The other thing is that rates of conveying prognosis were very low, and they're quite variable. And this is something that Bob was alluding to in the study of cancer diagnoses. what is it about the doctor-patient relationship that influences prognosis? Well, what it really comes down to is not whether we can all the time, but how willing are we to give prognosis? And to give prognosis is prognostication. So how good are we not only at defining or developing a prognosis, but really how good are we at conveying that to the patient or their family? As Bob already showed you the quote from Hippocrates, which I love, 400 BC, so 2,400 years ago, we can look at this quote and we can chuckle about how kind of out of touch this might be in current medicine. Oliver Wendell Holmes was a serious thinker in medicine who contributed a lot to our field. He didn't have much better to say, which was, your patient has no more right to all the truth you know than he has to all the medicine in your saddlebags. He should get only as much as is good for him. And as Bob also alluded to, the AMA Code of Ethics, medical ethics, as recently as 1947, and this language is direct from the Code of Ethics, grant reasonable indulgence to the mental imbecility and caprices of the sick. And not only is that a great use of caprices, but that makes everyone just stop. Now, this is something that is within many of our lifetimes, and yet this is how physicians have been trained. This is how they think, and they have thought. So how willing are we to convey a prognosis? Well, one of the things that influences that, and I think we see in those quotes historically, is the notion of beneficence, which is basically this form of paternalism. Well, I know what's right for the patient, and so I will tell the patient exactly what the patient needs to know and no more, because after all, I am responsible for what happens to the patient, and they don't need to know anything. But there's actually something that I think actually lingers less now than beneficence, which is this non-maleficence, which took me a while to learn to pronounce, and still longer to spell correctly since I didn't. Primum non nocere. So what does this mean? Well, first, do no harm. We as physicians are often worried that conveying particularly a poor prognosis to patients will actually influence the outcomes of the patient's care. We worry about the effect on, say, hope, as Bob was alluding to. We don't want to snuff out hope in a patient who has terminal cancer. I could argue that knowing you have terminal cancer is probably more helpful to you than me saying, don't worry about it. But nonetheless, we do think this way, and we don't want to extinguish hope because we really feel that it influences people's health. One other thing that we do, and this I think comes up in the ICU a fair amount, is that the terminal diagnosis, we believe, alters physician behavior. So sometimes when we discuss DNR status about patients, we'll say, well, if we make this patient DNR, we worry that maybe other physicians won't do as much in their care because they're DNR. And this is a concern that may or may not be legitimate, but it's something that's in the back of our minds often, is that if we convey a terminal diagnosis or we take some of these steps, that we're somehow influencing other parameters. And that's not necessarily true at all and shouldn't be. Lastly, there's this notion of self-fulfilling prophecy that one of the authors wrote was a non-rational, quasi-magical process, which is really what I aimed for in medical school. So this notion that if I tell somebody they're going to die, that they're going to die. And believe it or not, surveys of physicians still bring this up as something that is going on in the back of the mind. So where do we go from here with that as a background? So we're not really good at prognosis, and apparently we're not real good, and we often don't want to prognosticate. Well, certainly there's been a gradual change, and Bob already showed you these statistics about the patients being told about a cancer diagnosis in 1961 or 1979 or 77. And certainly there's been a tremendous amount of change in that regard. Patient rights have a lot to do with that, the right to know and patient autonomy. There's also recently, in particular, been much more attention to end-of-life care and prognosis because these things, as I've described, are intertwined. Can we be better at predictions? Well, certainly Renee and I are very familiar with scoring systems used in the ICU, such as Apache scores and SOFA scores, and these can be helpful. They're not always helpful in discussion with patients and their families, but it gives us something to hang our hats on when we say, in this situation, we would expect roughly a 40% mortality. Now, that's not necessarily what patients or their families are looking for, but that's a place to start. And just the lack of certainty itself is really important to convey, Because if patients feel that we really know but we're not telling them, that doesn't help anyone. We really need to be honest with our uncertainty. Lastly, there is a notion of transition from a temporal mode of prediction to a probabilistic. And what does that mean? Well, in a temporal approach, what is the approximate duration of survival of this patient is what we're looking at. And this is what we tend to think of as prognosis. In a probabilistic approach, it's somewhat different. When we ask, what is the approximate probability that this patient will be alive after some period of time? Now, that may sound nuanced, but we're a lot better at doing that, believe it or not. And patients actually are often relieved to have just that kind of prognosis or prognostication when we can't say, how long will you live? Well, best we know, you have a 20% survival at 6 months. That's helpful. It's not exact. But when we looked at, when people have looked at this is again in oncology patients, when we look at, now this is over here, this is the data, this is different data, but this is very similar to the data you've already seen. This is physicians and nurses who are making a prognosis. This is based on the temporal approach, how long will they live? And quite frankly, they're wrong a lot of the time. They're accurate down here, just above, like, say, 25%. But when we get out here, when we look at the ability to be probabilistic about survival, the numbers get much better. Now, some of that is just the way the study is done, but some of that really reflects the fact that we're better at doing that than we are at saying, you have 6 months to live. So with that, I'm going to finish, and I'm going to leave you with two quotes from, again, I love Christakis. In our rush not to abandon patients therapeutically at the end of life, we abandon them prognostically. I think this is something that we've all seen and that we continue to see. And as a result of a failure to prognosticate, let alone prognosticate accurately, patients may die deaths they deplore in locations they despise. And I think that's something that Renee very, very elegantly showed you with the data that she presented. So I will now turn it over to Ursula McVeigh, who is the Director of Palliative Care.
Thank you. Hi, thanks for coming tonight. Okay, so I'm going to do more of a broad view about advice for navigating a serious illness. And as you've heard, there's a lot of treatment decisions that people face in the final phase of their lives that goes beyond just the care they get at the end of their lives. I'd like to start with a general definition of palliative care. So palliative care is a specialty that aims to relieve the suffering and improve the quality of life for patients with serious illnesses, and also to support their families. Palliative care can be provided at the same time of any other medical treatment. And how we do this support and focus on quality of life and comfort is largely pain and symptom management, comfort with medical decisions, helping people think through their goals and values and the medical treatments that they're faced in making these decisions, and helping them come up with decisions that are right for themselves. We also help with disease preparedness. For your illness, what does the future hold? And when you look ahead, what are the things that you're worried about? We provide psychosocial, spiritual support, and we help the focus be on making life as good as it can be and helping people retain as much as themselves as they face a really tough illness. Palliative care is provided by multiple disciplines and by many people that aren't specifically identified as a palliative care specialist. Any nurse or any doctor who's caring for a patient with a life-limiting illness needs basic proficiency in providing this type of support. But there are times when people's struggles are so difficult that having a specialist who can put together the whole picture for somebody is helpful to them, and that's where palliative care specialists come in. Palliative care is provided by doctors and nurses and social workers and chaplains, and many other people that provide support to patients and families as they face tough illnesses. The philosophy of palliative care is based on the philosophy of hospice care. Hospice care is the best care possible at the end of life, and it's probably the best care possible for most people in their weeks and sometimes months leading up to the end of their lives. Hospice care is for people in their last 6 months of life, but palliative care looks at that type of support in the ways that people struggle close to the end of their life is also helpful much early in their disease course. So palliative care is need-based. It's not prognosis-based. It's not just for the end of life. So medical decisions, and I'm going to talk a lot about goals of care, because when we talk about medical decisions and patient choices in the final phase of their life and at the end of their lives, what people have the biggest control over is defining what are the goals of my medical care. And I'll tell you a quick story, but I took my medical board's recertification for general internal medicine just this year, and that's 10 years since I completed my residency training. And I am trained as an adult generalist and then palliative care. And in the entire board, this is the medical boards for all adult internists. There wasn't a single question on anyone who was at the end of their lives. There wasn't a single question on pain or symptom management. And I think that speaks to the medical training that we get, and the focus of what medical training is on is largely about treatment of disease. The other thing that was very difficult for the boards for me was a lot of questions were stated, what is the best treatment for this? And I just wanted to answer depends. Because in my work, what is the best treatment for a hip fracture? It depends. It depends on what the person's goals of care are, it depends on their prognosis, and it depends on how they weigh their priorities. And so that's where there's control over how people face the end of their lives, is what are your priorities? And we need to be recommending treatments that best suit those priorities, not just what in a textbook would be the best treatment for the disease. Goals of medicine used to be largely about relief of suffering before we had so many treatments for disease. But now largely, the goals of medical training are focused on optimal treatment of disease. But sometimes optimal treatment of disease is not the optimal treatment for relief of suffering. So what are goals of medical care? And I frequently find it helpful to break this up into two sets. And one set of goals might be the goals of medical care are optimal treatment of disease, or restorative goals, or the goals to get better, or the goals to prevent a premature death, or goals to do therapies to improve physical function, and goals to extend life. And the goals of medical care can also be comfort-directed goals or relief of suffering, like relief of physical symptoms and a focus on the best quality of life possible. Or for many people, staying in control is a very high priority through to and up to the end of their life. Or having a good and peaceful death on the terms of how someone defines a good death. And it's also support for families and loved ones, which is largely the number one concern that patients facing a serious illness have, is concern for those around them. And when we look at what the goals of medical care are, and someone comes in with an illness and they're suffering, and we can look at how to treat the disease, or we can look at how to alleviate the suffering. In the final phase of life, those two things can start to conflict, where optimal treatment of disease may not be the optimal quality of life, and there are trade-offs. And how people choose their trade-offs, or how they rank these priorities, changes. It changes through the course of a serious illness. And so I wouldn't want to be in the hospital, but if I had an appendicitis, I would sacrifice my optimal quality of life, which would be sleeping at home in my bed, for what is the best disease management to extend my life and prevent an early death. When someone's in the final phase of their life and they were to catch a pneumonia and they're weak and tired and the last thing they want to do is be in the hospital, optimal disease treatment might be to come into the hospital, but optimal control of their comfort and quality of life might be by having a system of care to care for them at home. And that's where these priorities shift and change. So when I meet somebody and they're facing a medical decision, I need to understand who they are and what they're worried about and what are their priorities, and helping them think through, for this treatment and for your priorities, what's the trade-off here? So life is kind of a highway. We know the destination at some point is that all our lives end. And as you navigate a serious illness, people's goals of care change along that course. And I'm going to use two metaphors that I may not like by the end of this evening, but one is these exit ramps when critical events happen, where you might have to make urgent decisions and how people respond or make decisions in that moment. And the other sort of way of looking at this as navigating is, what's the road like? And what are the other options for living each day? Not end-of-life decisions, but for day-to-day. What are my days like? What are my priorities? And do I like this road I'm on? And what would it look like to take a different path? So these exit ramps. When I help work with people that are facing a life-limiting illness, like at the onset of a diagnosis of a life-limiting cancer. So I have an example of a fairly young man who was just diagnosed with a malignant brain tumor. And he wanted to see palliative care. And his reasons for seeing palliative care was that he wanted to be sure that he had good end-of-life care. But what he didn't know was I could also be a support to him as he navigates this road up to the end of his life. And so he had things that mattered at the end of his life. And then I asked him, well, for now, he knows at some point his life is going to end from this. But what are your goals of care right now? So at the end of your life, this is what's important. And then what happens between now and then? You have control over that too. And he was undergoing chemotherapy and radiation because the goals were to control the disease so that he could minimize the symptoms of the disease and help extend his life. He was really worried when he thought about the end of his life. He was also worried about what leads up to the end of his life. And in thinking ahead of his illness and having known somebody who also faced a malignant brain tumor, he was worried about having his life extended in a state where it wouldn't be an acceptable quality of life. And so there were conditions under which his goals of care wouldn't be treating the disease. They would be something different, like focusing on comfort. And in the course of a serious illness, there are events that happen. And how you respond to those events are intricately involved in what are your goals of care? What are your goals of care at this time? And what are the outcomes possible from this event? And there are these serious events like somebody's heart stopping. In the setting of a serious or in the final phase of life, when somebody's heart stops, the outcomes from CPR, if somebody's already facing the end of their lives, usually lead to the end of their life anyway. So at that moment, if life is like a highway, and these are these exit ramps where events happen, we can try to keep the car on the highway and try to extend life and treat disease, but there are circumstances under which we allow the car to take an exit, and we focus on comfort and allow their life to end. And that's a decision like to withhold CPR if somebody's heart were to stop and they were to stop breathing, such that they've died. And so sometimes people make these decisions in advance that if this happened, that this is what I would want, because the burdens of treatment outweigh benefits. And that's a typical decision that is a thought process that happens for people putting in place not to attempt resuscitation. Or it might be somebody with advanced lung disease who, if they were to, when they meet with their pulmonologist who's talking about your illness is progressing despite our best efforts, if you were at a point where you couldn't breathe on your own, being on a breathing machine would be unlikely to get you better. I think that would be the end of your life. And so a person might put in place a plan, if I were so sick that I couldn't breathe on my own, I wouldn't want to be on a breathing machine because the likelihood is my life would end on a breathing machine, but instead I'd want to focus on comfort and allow my life to end from my lung disease in a comfortable way. The other reason why people make these decisions about how they treat an acute illness is based on what is their quality of life like at the moment when that happens. So you can't always think ahead, what would I do in this situation? Because it might depend on what's happening in your life or what stage of illness is happening. And this is that people put in place plans to less focus on disease and more focus on comfort as they get closer to the end of their lives and the burdens and the benefits become different. So in thinking ahead, in goals, under what conditions would your goals of medical care be comfort only and to not do treatment of disease to extend your life? And this is about in advance end-of-life discussions. And they found that talking about what matters at the end of life and under what conditions would your goals not be about aggressive medical care but about comfort has helped people prepare for the end of their lives. It doesn't always lead to concrete decisions, but having these discussions that can then inform making good in-the-moment decisions. And they found that people that have in advance end-of-life discussions have better care at the end of their lives, and their loved ones have a better bereavement process and feeling comfortable with what happened. This is from the Vermont Advanced Directive for Healthcare, And I like the way it's not about I want all treatments or I don't want CPR, but it respects that there's a time in everyone's life when it depends. Their answer to that question depends. And that's the middle ground of I would want treatments to sustain my life only if I would be able to, and people can decide which of these are right for them. Only if I can communicate with my friends or family, or maybe only if I can care for myself. The Vermont Ethics Network has this patient values questionnaire that I do like to use a lot when I meet with patients that are navigating their final phase of their life, but are not at the end of their lives. And this helps inform decisions short of the very end of their lives. And this type of process helps people formulate goals and values that then they can use as resources when they are facing difficult decisions near the end of their life. And this is a worksheet that's very useful to use with your loved ones. And it talks about what you value most about life. How do you feel about death and dying? How do you feel life should be preserved? Do you feel like life should be preserved as long as possible? Or if not, under what conditions would your goals not be to extend your life as long as possible? I won't go through all of these. And the other piece about patient choices. So patients can define what their goals of care are, and then as a provider, we describe what are the best treatments to achieve those goals. The other way of defining goals of care is not just individual treatments, but it's a general philosophy of care. And this I'm going to describe as, for example, like hospice care. Hospice care is wonderful care at the end of life and wonderful supportive care earlier than just the end of life. Hospice care can still include treatments aimed at controlling disease, but the philosophy of hospice care is about quality of life. So someone with heart failure, controlling their heart failure is very important for their quality of life while they're living with heart failure. And so on hospice, they can still have control of their heart failure, but as their illness progresses, you're escalating treatments at comfort and preparing for when someone's at the end of their life. So I had a patient who had heart failure when I was a hospitalist. He was in and out of the hospital, and he was also getting complications from being in the hospital, and he was getting weaker, and he did not want to be on that road anymore. So he was on the road of what we would describe as optimal disease-directed care. When he was going into heart failure, he was admitted to the hospital, and that involved hours in the ER and tests and coming into the hospital and getting medical treatment for his heart failure. And then he would go home, and he was coming back in with only being at home for a short period of time. And so we talked to him about what hospice care would look like. And he would still get treatment for his heart failure, but his goals of care would be about his quality of life as the priority. And he listed quality of life. The biggest thing for him was not being in the hospital and being at home. And hospice provides a system of care so that when he gets into trouble, he can get all of his care needs met at home with the support of his wife, who was his primary caregiver. And so he still had his heart failure managed, but there was a lot of supportive care too for him and his wife as his illness progressed and as he got weaker and preparing for the end of his life. And when his heart failure worsened, they called his doctor and they were adjusting his heart failure medicines. It wasn't stopping disease-directed treatments, it was just focusing on whatever we can do at the home and preparing for a good end to his life. And he was able to stay out of the hospital longer than I had seen in the entire year prior. And he had a wonderful quality of life for his final 6 months, and his life ended in a hospice facility in Williston. And it was a really, as a hospitalist, it really showed me that not coming back to the hospital doesn't always mean that your life's going to be shorter, but it is letting go. It's letting go that we don't know your labs every day. You let go of that. And you focus on priorities. And so in making these medical decisions, and especially for people facing the final phase of their life, people know, even with a life-limiting illness like metastatic cancer, people will know that at some point their life will end from that. And what we have control over is between now and then. And sometimes we have control over how long somebody lives. And then there's this cross in the road where people can look at changing. The road can be very different when you have a priority of quality of life and comfort versus the priority on optimal disease control. And how these roads are different is very different for each illness. It's very different for someone with cancer than somebody with heart failure. But they're very different roads, and they're both valid, and this is where people have control over how they're cared for at the end of their life. So in the top slide, sometimes the priority of comfort and quality of life might be a shorter road. It might not be the longest life possible because we're not doing everything we can disease-directed to extend somebody's life. But it might be the preferred road because someone might be prioritizing what their quality of life is like versus a longer road, which might be optimal disease control. There's also a point in a serious illness, in a life-limiting illness, when it doesn't matter what you want, that time is short, or that how long somebody has to live is not in our control. And in that case, the road you're on makes a very big difference. And so that's where prognostication becomes really important. And I see people struggle with these decisions where sometimes they're weighing these treatment options and the outcome is the same. And once you say that, people choose very different things. And if you were to ask one question, if you're struggling with a serious illness or someone that you love, and you just feel like we're not doing, you don't wonder if you're on the right road or are we doing enough attention to comfort and quality of life, is to ask a doctor or a nurse that you trust and say, what would my medical care look like if I prioritize things different? What would it look like if I prioritize comfort and quality of life over controlling disease? And what am I trading off? And sometimes you might be trading off time and sometimes you're not. And so knowing that and talking about somebody and just getting that information can really help give control over you stating what are your priorities and letting us recommend treatments that match those priorities. And these are the steps of a goals of care discussion. When we ask somebody what their goals of medical care are, or what are they hoping for, that's the first step. And then as a medical provider, we hear what someone's hoping for, and sometimes that's not possible. And that can be a bit of what we call delivering bad news. So someone might be hoping for recovery. So in the moment, they're choosing treatments that might be burdensome, but they think that they're going to get back to how they were a month ago. And so that's the first step, is for us to clarify, like, what is it you're hoping for, or what do you expect? And then as medical professionals, we have to help you know, if that's not possible, we have to be honest about that. Because you don't want to do burdensome things if they're not going to get you where you want to go. So that's this dialogue of what you expect, and then we help you know. And there's frequently a range of what's possible. So it might be, well, we hope for this, but we're also worried for some people, this is what happens. And then in hearing that, so this is what you want, but that recovery isn't possible. We don't have control over that. But in hearing that, for what we can control, what are your priorities now? And then when there's conflicting goals of quality of life and optimal disease control, or living as long as possible, is helping people see which of those are they prioritizing now. And then from that, once we've identified goals of care, then we can talk about, well, this is a good medical plan and this is the best care possible. And that's my talk about goals of care. Thank you.
So, Jennifer, I just wanted to ask you, with the delay we had before, would you still like us to finish up at 7:30, or are we thinking we're going to go for another 10 or 15 minutes because of the break?
20 minutes, and then we'll make a decision on that. So it's about 20 after 7.
Okay. Well, I would say to the audience, if we end up running over time and you need to be done at 7:30, it's fine to excuse yourself. No one's going to be offended. We understand. So just very briefly, in the interest of time, I was supposed to come back and kind of summarize the hour with a series of practical tips. And I know you all have your slides in front of you, so I'll just go through this really quickly. I would say start decision-making early. Don't delay. Don't wait until it's too late. Going through this process for one of your loved ones as a surrogate is very, very burdensome and hard on them. So while you're able to make decisions for yourself, please, 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 please do. It makes life so much easier for everyone. Think about your goals and values, what's important, what kind of quality of life is acceptable. Is it okay for you to be in a nursing home, or is that absolutely not something you would ever want to do? Learn all you can about the treatments and their burdens and benefits. Make your provider prognosticate. Doctors are terrible at bringing up end-of-life discussions. as a group, we are really bad at it. And if you go into a visit and you want to talk about this and your physician doesn't bring it up, ask them. And I would say take someone with you to those visits too, because you're going to need another set of ears and eyes to maybe take notes. So a lot of times patients only hear, we're all human, right? We only hear part of what's said to us, and it's good to go through reiterations again and again. One of the most important things to me as an ICU provider is to talk to your family beforehand, talk to your loved ones. Tell the people who are going to be making decisions for you what you want. Ask your providers for help. If you're the type of person who wants to get a recommendation from your provider, it's fine to ask for that too. I think my job as a provider is not to convey my own end-of-life wishes onto my patients. It's my job to find out what you want me to do and help you do that. If you're the kind of person that wants to hear all the details and make your own decisions, that's great. If you're also the type of person who wants me to give you a really strong recommendation, I can do that too. Just ask your provider for assistance if you need that. And then again, once you've decided, tell your loved ones and your providers and complete the paperwork. So there's lots of paperwork and forms. You've probably heard the term advance directive. How many in the audience have one? Wow, good for you guys. So one thing that I want to drive home, and I think the other panelists can speak to this too, read your advance directive again. An advance directive is often not enough, despite what we all think. So the way that most advance directives are worded is there are a few sentences in there that say something like, if I'm ever in a situation where there's absolutely no hope of meaningful recovery, I do not want life support. And we all check yes on that. But at the end of the day, when the physicians are faced with that, we can never say that there's absolutely no hope of recovery. That's an absolute statement, and that's not a possible thing, ethically or legally, to say. And the ethics and legal part, I'm going to leave to Dr. Macauley because that's what he does for a living. But unless, often on advance directives, unless you put in specific wording about what you do and you do not want, it isn't really enough. That absolute happens in brain death and kind of nothing else. The rest of it's various shades of gray. So that's why you need a durable power of attorney for healthcare, like Dr. Macauley talked about, naming someone to make your decisions, who you trust, and talk to them about what it is you want. So if you have a sudden arrest and you're in an ICU on life support and can't make decisions for yourself, that person can say, you know what? I had a conversation with them 3 months ago about this, and this is what they want. It relieves that person incredibly of the burden. And then in Vermont, we're lucky. We also have something called a COLST, Clinician Order for Life-Sustaining Therapy. Other states, it's called a POLST, Physician Order for Life-Sustaining Therapy. I know you can't read this from back there. This is the second and third page of the form. This is a legal document that is specific. This one is specific to Vermont, and it tells all of us whether you want to be resuscitated with CPR, like we talked about, whether or not you want to be on a breathing machine, whether or not you want to go to the hospital, whether or not you want to get antibiotics and artificial nutrition, and so forth. These forms are available in doctor's offices. They do need to be signed, but the idea is that you complete these with your provider, and they go on your refrigerator. And ambulance personnel and emergency personnel know that when they come to your house to look there, and if they see this, that you don't want anything, they won't do it. So this is how you opt out. All right, let's open it up for questions. I have 7:25. If you have a question, go ahead, raise your hand. I'm going to sit down, and we'll try to call, and whoever can answer will answer. If you need to get up and go, feel free. Let's just go from there.
Last spring, the legislature passed a bill allowing terminal patients to choose to terminate their suffering early. Do you respect their decision? And what medication do you give out? Is Nembutal preferred medication? And when they're on that path that we saw, they can choose the shorter path or the longer path. If they want to 6-month prognosis, will you accept the shorter path, or do you look at the longer path?
Why don't we take it in turn? So let me make sure everyone's on the same page with regard to what the gentleman was asking about, and then I'll turn it over to Dr. McVeigh with some goal setting. So the Vermont legislature this year did pass a law that says that if a patient has a life expectancy of 6 months or less, that they have the right to request and obtain a lethal dose of a pharmaceutical. It doesn't specify in the law what that is, what precise pharmaceutical is used. There is a very specific outline in the law of what is required. It isn't a snap judgment. There needs to be 2 oral requests and 1 written request separated by at least 15 days. So there needs to be sort of an inherent waiting period in there. And no patient is obligated to use the law. No patient is obligated to request a lethal prescription, and no physician is obligated to provide a lethal prescription if asked by a patient. The law does not specify a certain pharmaceutical, so there's a little bit of a question about what to use. There's knowledge of what is used in Oregon, where the law has been in place for since 1997. It's been in force since 1997. So the way that I think physicians in Vermont are handling that is that some physicians do not want to participate, and so they have the right under the law to say, I choose not to participate and I'm not going to write this prescription for you. Some physicians are going to be willing to participate, and there's a very clear outline in the law about the steps that are required in order to do so legally. So I think that it's up to each individual patient to decide if that is something that they're seeking, and each individual physician to decide whether that is something he or she is willing to do from a legal perspective. I turn it over to Dr. McVeigh for more goal setting and bigger picture stuff.
Sure. So when you look at other states that have physician aid in dying legislation and the use of this, the intent of using a medicine to hasten death near the end of life, it's very uncommon. It's a very small number of people who die who use that option. When they ask patients why it is that they choose that, it's largely about maintaining control and relief of suffering near the end of life. Having thoughts of hastening death are very common with serious illness, and there's a large burden of symptoms. And suffering isn't just physical, it can be emotional and spiritual, it can be loss of identity. And people can have physical discomfort but not describe themselves as suffering. And some people describe suffering as when discomfort is meaningless or meaningless suffering. And when I talk to patients that are navigating the final phase of their life, and a lot of people are asking about physician aid in dying now as a tool, and I ask them what it is that they're worried about or under what circumstances would they think they would use that. And it's largely that people are worried that they'll be left in a state of suffering without an exit ramp. You know, where they're, and it's frequently, for the small experience that I've had so far, it's frequently people who are currently doing disease-directed care for the goals of maintaining their life for as long as possible. This is work in the oncology clinic. But they're worried, not just worried about their care at the very end of their life, but they're worried about having unrelieved suffering near the end of their life. And a lot of people are worried about having uncontrolled pain. And for the things that people are worried about control, over not extending a prolonged dying process, over suffering physically or emotionally or physically, we have a lot of ways to address that within all the tools of hospice and palliative care. And for most patients, the things that come to mind when they're worried about or why they might consider a medicine intended for hastening death, it's largely achieved by defining goals of care or stop preventing dying or focusing more on comfort, and then within that allowing a natural death. There are people that face difficult suffering near the end of their life, but don't have an exit ramp where their life isn't ending. And those are the people where taking a medicine that hastens death to bring death closer, because extending living with this degree of suffering that hasn't been able to be alleviated, that people would define that as having a good death. Other things that people endorse thinking about physician aid in dying, of why that would define a good death for them, is there's something about having it be controlled or having family around and having control over their last hours of their life. And what I believe, and a lot of the doctors are kind of wrapping their minds over, how comfortable do I feel in the physician's role of prescribing a medicine that hastens death? And without getting into my personal belief system, what I do believe is the only person's opinion of what constitutes a good death is the patient themselves. And I always align with patients and families that whatever is happening, we will alleviate your suffering at whatever it takes to get you comfortable. And we will be here now, we will be here for you when you're at the end of your life. The drug that's used in other states is a barbiturate, which is a drug that in very high doses depresses the respiratory drive and people stop breathing over a period of hours.
Are there provisions in the Vermont law that has been recently enacted for someone who is not diagnosed with 6 months to live, but who has an illness like Lou Gehrig's, to request physician-assisted dying prior to that period of time, prior to the 6-month period?
No. The law specifically states you need to have less than 6 months left to live. And so there are certain patients who would not qualify under the law if by the time they reach as by our best projections, the last 6 months of their life, if they can't fulfill the other requirements like self-administration or giving consent at that time. So you can't, for instance, give consent in advance in case that you develop severe dementia or something like that. That's not covered under the law.
For Dr. Suratt, the difficulty and inaccuracy of prognosis, we see the 6-month timeline as being a potential issue after your statistics that say people are so inaccurate at predicting prognosis.
Was that a question or an observation?
It's an observation I'd like to know your thoughts.
Well, so the question was basically, what are my observations based on my discussion of prognosis and prognostication of the requirement for a diagnosis or a prognosis of 6-month survival in order to activate the recent law. Well, we all struggle with trying to understand what this law will mean for us and our patients. I think one of my major concerns really is just that. I think we're all uncomfortable with the notion of a 6-month prognosis when, whether we look at it statistically in studies or we look at it anecdotally, we have all experienced the fact that our ability to determine an accurate prognosis is pretty poor. I think that you can argue the data on two sides in that case. I think the data certainly support the fact that, if anything, we tend to be over-optimistic. So one could say, if we say you have 6 months to live, well, then at least according to the studies, you probably have less. But that's again kind of a gestalt. I don't mean to be flip about that. I mean, that's what the data suggests. I personally am very troubled by the fact that this law really is predicated on that notion of 6 months survival, because I don't think we're that good at doing that.
All the way to the back.
I have a question on palliative services. By the way, you did a beautiful job. I cared for my 2 parents at home, palliative and hospice care, and it's the best of all. So I'm really happy that you are completely sensitive. But I have a question about Alzheimer's patients. Are they allowed to, or they qualify for palliative services despite the fact that they might live longer than we think, or not?
There's a lot of work that's being done to identify the needs in palliative care for patients with dementia. And palliative care is largely provided through either patients' primary care doctors or nursing home staff or home health. And people can get palliative care even with an ambiguous prognosis, or even if they have an illness that extends for months or years, that has a very difficult course. One of the largest burdens of dementia are the physical and cognitive changes that require caregiving support. And they've identified that stress on caregivers is a major unmet need of palliative care support. It's not just the patients themselves, but there's probably it's an illness that has a great effect on families too. And I don't think we have optimal support in that realm. But palliative care is available, either home-based care if a patient were homebound and had a skilled nursing need. A home health agency could have a palliative care nurse that could attend to palliative care concerns like pain management or family psychosocial support. Hospice care for dementia is very tricky because it's hard to prognosticate for dementia patients. And they did find that dementia patients on hospice live longer than expected. It's very good supportive care, and there is an instance with frailty, how sometimes less is more, like avoiding going into the hospital and avoiding things that might upset your homeostatic balance of your body. And then a lot of patients have to be disenrolled from hospice because they rally. So it's a real unmet need, I think, in our community and really around the world.
I would only add that one thing that we've all seen hospice alumni who have made it beyond the 6-month of enrollment, and truly dementia is one of the most common diagnoses in which that occurs. But I think also as we begin to take in palliative care in general and not necessarily focus on 6 months and hospice, I think that there's enough of an overlap that it doesn't necessarily mean that patients will be excluded. I would also observe that there was a study, I think 2 years ago now, New England Journal, that looked at patients with advanced lung cancer who were randomized to hospice versus continued aggressive therapy. And unless one of my panelists corrects me, I believe the finding was that the patients who went on palliative care actually outlived the patients who had ongoing therapy.
Yes, sir. So it's almost time for me to renew my CPR certification. Is it working? It sounds doesn't really matter. Should I think twice about it?
Well, the gentleman in the back commented that he needs to renew his CPR certification soon, and why maybe he shouldn't even bother. I think CPR as a procedure was actually developed in the late 1950s, and it was really intended to be used on the subset of people who had just undergone open heart surgery and then had arrhythmias like ventricular fibrillation and tachycardia, which are more survival than other arrhythmias, to try to resuscitate them without having to open up the chest again and pump the heart manually from inside. In that original study, actually about 70% of the people survived, but it was a very, very narrow group of people. And over time, for a lot of reasons that I don't think we clearly understand, it has evolved into something that everybody gets from ambulance personnel, no matter what, unless you have documentation to opt out. Certainly, it is a procedure that has saved a ton of lives, because without it, you die, right? But I really believe, and I think all of us believe, and a lot of physicians believe, that we're coming to understand that in many cases it's a very burdensome procedure that leads to weeks to months in the hospital or acute care facility afterward with a much lower quality of life than before. And especially for people who are probably nearing the end of their life and have underlying chronic disease and a lower likelihood of survival, it's really worth some discussion and thought beforehand with the provider and family to figure out if it's something that you really want.
You should recertify.
So it's about 20 to 8 now. I think we all appreciate everybody sticking around, especially with our delay. Thank you again very, very much for coming.